experience of as a medical technologist in this prestigious institute since 2003 to 2006. Then I got an opportunity in Roche Diagnostic Division. Then in Roche, I have spent 7 years as a product manager for the centralized diagnostics since 2017 till 2013. Then I was responsible in a Roche as a product manager for Pakistan only. Then I got an opportunity in Abbott Diagnostic Division as an application manager and NPS coordinators. So I was responsible for ADD affiliate in Pakistan, which includes the countries like Sri Lanka, Bangladesh, Maldives, and Afghanistan. So then in 2023, April, I got an opportunity to join SNIBE as a training manager consultant for Asia. So my reporting is to Ziv and Zui. So this is all about a brief introduction for myself. So let's start with the presentation. Today we have a presentation on first the prenatal screening reagent and software. So in this presentation, we have two major parts. The first part contains a genetic defect disease and the SNIPE solution for the congenital diseases. And then what are the assays where that SNIPE is offering from the Meglumi platforms? What are the parameters are available? Along with that parameters and the assays, we have a comprehensive solution of a prenatal screening software that's called Preco. So this software is very helpful to analyze the risk analysis of that congenital abnormalities or anomalies. So that's why this presentation has the two parts. So let's start with the genetic defect disease and the Meglumi solution from the SNIPE platforms, what we have. So if we talk about the congenital anomalies, basically it's a condition in which by birth there is some cause is not regardless, which may be due to the disability, either the physical, mental, or developmental disabilities occurs in the newborn. That's reason that we call them congenital anomalies or abnormalities. So it is estimated that globally we have around 295,000 newborns died within the 28 days of the birth every year due to this congenital disease. And you know that the congenital disorder is caused a further 170,000 deaths of the child between the age of 1 month to the 5 years. So the highest proportion of congenital disorder abnormalities belongs to the CNS, that's 7.7%. And then followed by the musculoskeletal, that's the 23%, and the gastrointestinal systems, that are 20.8%. So globally, it is estimated that 8 million newborns are born with a birth defect every year. So this is the birth of congenital anomalies worldwide. It's in 8 millions. So in which 9 out of 10 are born with the severe birth defect are in the low and middle income countries. So this all global epidemiological distribution of congenital anomalies is mostly is a 60% in poor countries. And if we talk about the middle income countries, this congenital abnormalities is 34% in the middle income countries, and in the rich countries, it's just a 6%. So these are the percentage-wise distribution of congenital anomalies. You can see that the areas which is more prone to or a prevalence of epidemiological distribution of congenital disorders in these countries, like in Brazils, and then American regions, and then in these regions of Asia's, and then the Australia regions are more prone to these. So this is about the global epidemiological distribution of congenital disease. So if we talk about the prenatal screening, what is the prenatal screening? Basically, a prenatal screening is basically a checking procedures in which the first trimester and in a second trimester during the pregnancy, those who are a high risk of particular birth defect, and then they have detecting a birth defect by either through the invasive procedures or a non-invasive procedures. So it may usually used to screen out the genetic defects like such as Down syndromes, neural tube disorders, 18 trisomy syndromes, and 13 trisomy syndromes, and so on. What is the importance of the prenatal screening? Actually, the prenatal screening is very important for the pregnant woman. Excuse me. So because the relative genetic defect is incurable currently, and you know that in the Europe, like Austria, France, and in the Middle East, like Sudan, African countries, Saudi Arabia, the poor country prevalence cause, basically the cause of this congenital disease is due to the insufficient folic acid intakes, the nutritional deficiency, exposure to the certain environmental factors contribute to the neural tube defect in low income countries. So, you know that in congenital disorders, the most common or the severe is a heart defect, neural tube defect, and the Down syndromes. So that's why this, and it's incurable after that. So that's why during the pregnancy, it's more important to have some screening assays. So if we talk about the Down syndromes, so do you have any idea what is the difference between syndrome and a disease? So let me share with you. So you know that the disease can be defined as an healthy condition that has a clearly defined reason behind it. But the syndrome is a Greek word which means run together. So it's a refer to a group of symptoms, while a disease refer to an established condition but don't have a clear cause, course, or a treatment path. So that's called a syndrome. So if we talk about the specific characterization of the Down syndromes, the Down syndromes is basically is the trisomy 21. It's a typically a mental retardation which is caused by due to the presence of one excess chromosomes at chromosome number 21. So the rest of the chromosomes are okay. There are regular chromosomes at the pairing between the 18, 19, 20, and 21. But in the Down syndromes, there is a one extra chromosomes, which is the most common chromosomal disorder in the world and more severe disease. And there is no way to cure and prevent. This is most important. That's why prevention is better than cure, and that's why so the prenatal screening is more important. So there's still the cause of that Down syndrome is not clear, and they have no influence. Only they are suspected that there's a cause maybe due to the insufficient folic acid intake or some nutritional deficiency or some exposure to some environmental factors. So if we talk about the risk of Down syndrome increasing as a woman age, you can see here that the prevalence of Down syndromes per 1,000 birth is increased with this age. You can see here that this is an area between the 45 to 50 years of age. There is a higher risk of congenital diseases, especially the Down syndromes in the women. So if we talk about more the sign and symptoms, uh, so the babies which are born due to the Down syndromes have an extra copy of one chromosomes 21, and the radiological imaging helps them to find the clinical finding in that patient, including the invasives and non-invasive procedures. So the first non-invasive procedures for the rule out of the Down syndromes is radiological imaging. So what are the typical features that the Down syndromes baby has? They have a natural thickening, which is this area, which is ideally recommended that the natural translucency should be less than 3.5 millimeters. And then the baby has an people with the Down syndrome usually have an IQ in the mild to the moderate low range, and then slowly to speak than other children's. And this is the after the birth symptoms, but during the pregnancy and the fetus development, the other radiological distinct feature that helps to diagnose that this baby is suspected at a high risk of a Down syndrome, as that's an echogenic intracardiac focus. They, along with that, polydectasis and the widened pelvis. So these are the regions where we can conclude during the image of that fetus that there's some abnormality. The other is a shortened limb. There's a sandal gap, and then hypercolic bowel. So this is the hypercolic bowel, and then they have a hypoplastic nose and the clinodactyls and the brachycephaly. So these are the typical clinical features for the Down syndrome's fetus. And then the possible conditions, if they such babies born, so maybe they born with the congenital heart disease, they have some gastrointestinal abnormalities, or they have some spine disorder like sclerosis, kyphiosis, and lordosis. So these are the findings during and after the birth in Down syndromes babies. The second genetic disorders or syndromes is basically an Edwards syndromes. So you can see the Edwards syndromes. Another name is the trisomy 18. The main characteristics of this trisomy 18 is a second most common cause of autosomal trisomy in the newborns, and they have a 90% of cases are the results of the maternal non-disjunctions of the chromosome 18. So it is almost always lethal. Majority babies dies before birth, and then the low survival rate. If they survive, there are possibility of heart abnormalities, kidney malformations, etc. And the symptoms, which are typical for the Edwards syndromes, they have a small mouth with a small jaw and short neck, malformed ears, dysplastic or malformed ears, widely spaced eyes are one of the typical examples or clinical findings of such Edwards syndromes babies, and then the clenched hands. So with the overlapping fingers and the flex big toe, prominent heels. So these are the typical features of the Edwards syndromes, and on the basis of this, during the screening, that can be ruled out that the baby belongs to the Edwards syndrome. So if you talk about the characterization of the Edwards syndromes, that's in trisomy. So in this trisomy, the symptoms are a small head, small jaw, clenched fist with the overlapping fingers, and the severe condition in which, if we goes to the chromosomal analysis on the 18 numbers of chromosomes, there are one extra chromosomes. That's a third copy of chromosome 18, which may leads to these genetic disorders. And then the main complication for this Edwards syndromes is basically in heart disease, intellectual disability, the breathing difficulties, and the growth deficiencies are the major complication of Edwards syndromes. If we talk about the risk factor, advanced maternal age, the age factor is very much important for the risk analysis of this congenital diseases like Down syndromes, Edwards syndromes, or neurotube disorders. The prognosis is very low. The 5 to 10% survive past years old. So if we talk about the epidemiological distribution, global distributions is about 1 in 5,000 live birth, but more conceptual about affected by the syndromes, because the majority of these diagnoses with the condition prenatally will not survive to birth. So this is very important. This is more lethal as compared to the other congenital disorders. So if you talk about the neural tube defects, so you know that the neural tube defects are called NTDs, the basic abnormalities that occurs in the brain. That's why we call them neural tube disorders or spinal cords or spine or developing fetus. So there are a few examples in which the craniocysis, the anencephaly, anencephaly, these are the basically a typical complete open brains and the spinal cord, and this in this case the open brain and the lack of skull's wall is there, and then the encephalocele, there is a herniation of the meninges and the brain, and then the inulocephaly, the occipital skull's spine defect with the extreme retroflexion of the head. So you can see that these are the all related to the neural tube disorder, and the most common neural tube disorder is the spina bifida occulta. So in the spina bifida occulta, the closed asymptomatic entities in which some of the vertebrae are not completely closed. So this is a typical neural tube disorders and most common neural tube disorders. The closed spinal dysraphisms, basically a deficiency of at least two vertebral arches here covered with the lymphoma. So this is a typical condition in which the closed spinal dysraphisms occurs. If we talk about meningoceles, that's the neural tube disease in which the protrusion of the meninges filled with the CSF, and then through a defect in the skulls or the spine maybe occurs. So the other condition with the open spinal cord with the meningeal cyst, this condition is also belongs to the neural tube defects. So these all different types of neural tube defects. So if we characterize these neural tube defects, you can see that the neural tubes in the spines or the brains remains involved. So the most common type is spina bifida and anencephaly. These are the two typical common type of neural tube disease and defects. And then the cause is a folate deficiency and genetic disorders. So as of today, there is no cure and the treatment, but it's a permanent damage. You can say during the fetus development, that's an anomalies occurs. So the frequency is over 300,000 births each years worldwide. This is an high figure as compared to this and the productive effect. The folic acid utilization is most important, which can be protect the neural tube defect, the fetus development, and then have a very important role of folic acids. It's now well recognized, and according to the recommendation, if the women who are at a higher risk, they have to take a 4 milligram per day, and if it's a low risk pregnancy, they have to take a zero point 0.4 milligrams for per day. That should be starting with before the 1 month of the pregnancy and during the first 3 months of the pregnancy. So that's an important medication which is usually used during the pregnancy. So if we talk about more the prenatal screening methods, so we can classify these prenatal screening method into two types. One is called an invasive, and second one is called a non-invasive. As you know, there are two types. One is called in vivo sampling, means the baby's amniotic fluid or some other samples. That's an invasive procedure for the fetus and the mother as well. And there is the through this invasive procedures, that's an gene analysis or karyotype analysis. So the other part is the non-invasives, which has no invasion or invasive procedures in which they have some radiological or imagology or a radiological image that helps to diagnose such genetic anomalies, and the serological testing, which play a very vital role as a non-invasive for the diagnosis of some genetic disorders. Any question? If you have any question, you can stop me or you can ask me. Or if I'm moving fast, please let me know that if it's fast, so I can make my pace a little bit slow. Okay? Okay, thank you. So, if we talk about the invasive screening methods, so there are three basic invasive screening method. The first is called amniocentesis. That's called AC. In amniocentesis, you can see that the needle through this needle aspiration, the amniotic fluid has been taken and then testing for the different methodology and then to rule out the congenital this disorder. So the second is the chorionic villus sampling. That's called CVS. This is trans-cervical chorionic villus sampling procedures. You can see here, this is a process through which the sample has been taken. The other type is the peri-umbilical cord blood sampling, PUBS. They are highly sensitive and they are highly specific, around more than 99% their sensitivity and specificity. But the risk is infection and abortion. So these are the two high risk factors for these invasive procedures. So also they takes a longer time to get the results. It takes around 3 to 4 weeks to acquire results from the amniocentesis, chorionic villus sampling, or the peri-umbilical cord blood sampling. So the cost is also high. So all these reasons, due to these reasons, these invasive procedures utilization are for now these days for the confirmatory test. Now the other part is the radiological imaging. Sorry. So if you go to the radiological imaging, the important and typical picture is natural translucencies. Translucencies for the natural, you can see here, this area is called neutral translucency. So the basically a baby measures nap-clear translucent space. If its natural translucency is less than 3.5 millimeter, so it considered as a normal. This is the normal baby during the ultrasound image of a fetus. So if this natural translucency is greater than 3.5, it should be considered as an abnormal. So this is usually done as a typical age of 11 to 14 gestational week, and then this clear translucent space is expected. If it's not, then it's may leads to some neural tube disorders or some other abnormality. So if you go to the non-invasive prenatal screening from serological testing, like measuring serum markers in the pregnant women at the early stage, and then they input the results in some maternal information or a prenatal software. That's another important steps for the prenatal screening. And then the software will calculate the risk of the birth defect. This is the risk of birth defect analysis through the software. So the first measuring serum markers, which are available from the SNI platform, Meglumi analyzers, we have alpha fetoprotein, free beta HCG, total beta HCG, PREPA-A, UE2, etc. And along with that, for the software, we need an age, gestational weeks, weights, and etc. Some more information which helps to check the risk assessment of the fetus and the possibilities of birth defect risk analysis. So, so if we go to the further maternal serum screening. So you can divide into 3 trimesters. From week gestationals to the till 12th week, it is considered as an first trimesters, right? So this is the first trimesters. In the second trimester, you can see that this is from 13 to the 20th weeks. So the first trimesters testings recommended are PEPA A, free beta HCG, or NT. Sometimes with the 2 these tests, this natural translucency is also that's the non-invasive procedures just perform. And then if the PEPA A and free beta HCG ultrasound screening of naturals, these combined tests are positive, then invasive procedures is recommended. That's a biopsy of the chorial villi. So the borderline is yes, between the second trimester, between the week 15 to 18, the alpha fetoprotein, beta HCG, and free beta HCG with free estriol, then the ultrasound screening helps. That's called a triple test. That's called a combined test from the first trimester. In the second trimester, it's called a triple test. So if the triple test is positive, then the amniocentesis is recommended, which is an invasive procedures. For the second trimesters, you see here there are 2 items, either the alpha fetoprotein, HCG or free beta HCG, or 3 items, alpha fetoprotein, HCG or free beta HCG, along with the free estriol, or the 4 items, alpha fetoprotein, HCG, free beta HCG, free estriol, or inhibin A. So these are the all testing which are required. And then the confirmation through the invasive procedure, because the sensitivity or specificity of the invasive procedure for the prenatal screening is greater than 99%. So with the non-invasive procedures, there's the one process of we call them multiple of the median, MOM. So there's a procedure to calculate the multiple of MOMs, which is based on the regional median values and for the more accurate risk calculations. So if we talk about the MOM, how to obtain the MOM, so these are the gestational week, like 16, 16, and 18 gestational week. The patient alpha fetal values along with the median alpha fetal values, you have to calculate the ratio, and then the MOM values gives you the value. So how to calculate the MOM? The MOM is obtained by dividing the test results. So these are the test results of the patient, for example, and of a certain pregnant woman to the median value of the population. If we check the median value of the population, so it will check the how far is the result of this pregnant woman is average values of the normal population. So so this helps to calculate the MOM. And then we go to the further assessment. If we go to the next, we can see that there are more relevant serum markers as in non-invasive procedures like PEPA. That's basically a glycoprotein which is produced by the fetal. So you know that then in the fetal, you have to check the rule out the Down syndromes and the trisomy 18 as well. And this PEPA is a glycoprotein which is by the fetal complement activation, and the immune inhibitions. And then this markers also rule out the Down syndromes and with the trisomy 18. If we talk about the free beta HCG, basically it's a subunit of human choriogonadotrophin. That's in the gonadotrophins. There is a no cross reactivity with any pituitary glycoprotein hormones, and it's also a specific marker for the screening of Down syndrome along with the trisomy 18. So this is the free beta HCG values in effective case in this area. This is the curve, and then the Down syndrome, the value of free beta HCG is most like this. So if we talk about more relevant markers for the prenatal screening, we have markers like the alpha fetoprotein. So again, this is a glycoprotein which is mainly generated from the fetal liver. So that's why this alpha feto assay is utilization is not only in the congenital disorder, it's also in the testicular cancers, hepatocellular carcinoma, and trisomy 21 and trisomy 18 and neurotube disease. So again, you can see that there is a graph of values, mom values during the Down syndromes and unaffected. You can see here, this is belongs to the Down syndromes. The value between the Down syndrome is 0.3 to 2 values as compared to the 0.4 to 2.8 value in unaffected patients. So if we talk about the free estriol, that's an steroid, it's a weak estrogen. It's increased apparently only during the pregnancy. And then this is specific tumor marker for the Down syndromes and trisomy 18 as well. So you can see that the MOM value for this free estriol, you can see here that the between the 0.3 to 1.6. So this is an early marker for the as a non-invasive for the congenital disorders. So if we go more about relevant serum markers, so the maternal serum analyte screening, how we can diagnose or this through this triple testing, which is the more accurate if done between the 16 and 18 weeks of gestation, but it can also be done between the 15 to the 22 weeks of the gestation. So if we talk about analytes like alpha fetoprotein is increased, SCG is normal, unconjugated estrol is normal. Only the alpha fetoprotein is increased. So this is suspected neural tube disease. So the ultrasound has to confirm the gestational age. If wrong EGA, then the recalculate the test and recollect again analyze. If it's confirmed EGA, then the repeat levels and the ultrasonic fetal survey with or without amniocentesis for the alpha fetoprotein and acetylcholinesterase test. So these are other testing which includes the invasive procedure of amniocentesis is more required as a confirmatory after having an initial screening with the alpha feto HCG and unconjugated estriol. If we talk about the triple test history during the 16 to 18 weeks, which is an ideal time duration for the testing of this, if the alpha fetoprotein is decreased, the beta HCG, that's in a free beta HCG, right? So the free beta HCG, sorry, the free beta HCG is increased and unconjugated estriol is decreased. So in this typical case, this is a suspected trisomy 21. You can see that that's in a Down syndrome. And then it's go for invasive procedure of amniocentesis for the chromosome analysis. So if the alpha fetoprotein is decreased, free beta HCG, that's in a free, not a total, right? So if unconjugated estriol is decreased, and along with the free beta HCG, all these parameters are decreased during 16 to 18 weeks or 15 to 22 weeks of the gestation. That may lead to the suspected trisomy 18. So for the trisomy 18 confirmatory testing, again, the amniocentesis for the chromosome analysis is recommended. So according to this triple test screening results, the neural tube disease, trisomy 21 and trisomy 18 are evaluated on the basis of these non-invasive serological testing of alpha fetoprotein and then free beta HCG and unconjugated estriol. So these are the three specific prenatal markers to rule out as a triple test for the maternal screening purpose for the neural tube disorders. Any question? Okay, just give me 1 minute. So I have to. Okay, thank you. Just give me 1 minute. I have to take one. So, okay, so what is the changes in the prenatal screening indicators? Like if we talk about other assays with the early stage of the pregnancy, in the midterms of the pregnancy, you can see that if we see here the disease or syndrome like condition of trisomy, Down syndromes, and Edwards syndromes, and neural tube disease. Their early stage pregnancy non-invasive markers are PAPA A and the free beta HCG. In the trisomy syndrome 21, that's in Down syndromes, the PAPA is decreased and the free beta HCG is increased. And if it's in a midterm pregnancy, they are doing a triple testing of alpha fetoprotein in the 21 trisomy. The alpha fetoprotein values goes down, and the beta HCG is increased, and then free estriol is also decreased. In case of 18 trisomy, as an prenatal screening indicators in the early stage of pregnancy and the midterms pregnancy, the PAPA is the early stage marker for the rule out of 18 trisomy syndrome that shows that it's in a decreased value with compared to the free beta HCG is also decreased. But for the midterms pregnancy, alpha fetoprotein and the free beta HCG and free estrol value, all those goes down. For the neural tube disease, that's in an early state pregnancy. This is not PAPA A and a free beta HCG has not clinically correlate with the neural tube disease. Alpha fetoproteins gives you the evidence during the midterm pregnancy for the neural tube disorders. So this is the reason why these non-invasive assays, prenatal screening assays, are helpful for the diagnosis of congenital disease. So if we talk about the cutoff value for the PRECU, so this is the software that SNIVE is providing solution from them. The cutoff value, the age risk, the trisomy is 1:150 is the cutoff value. And the trisomy 18 by 13 is a 1:300, and neural tube disease is less than 2.5. So these are the cutoff of these syndromes like trisomy 21, 18, and 13, and neural tube disease. The cutoff is 150, 300, and 2.5. With the result interpretation, if the X value is greater than 150, we consider as a low risk. If it's less than 150, it's considered as a high risk. With the same with the cutoff values, low risk and high risk in the trisomy 18 and 13, and then neural tube disorders. So basically, it's an available gestational range between 8 to 20 weeks, and the first trimester 8 to 13 weeks, and the second trimester 14 to 20 weeks. These are the trimesters in which they can assist the screening assays for the risk assessment of a low risk or a high risk differentiation on the basis of these values. So if we move for the other, what the solution that the SNIVE has provided from our platform. So like the other competitors, they do not have a comprehensive menu for prenatal screening. Only the SNIVE has given a one window solution for these assays. Like we have alpha fetoprotein, PAPA A, free estriol, and then free beta HCG. So these all assays which are which are required for the prenatal screening. We have a very comprehensive menu, while the other competitors they have missing free estriol, or some are missing the PAPA A and free estriol, and some are missing the free beta HCG. So the only one company has a very comprehensive menu, but the challenge is they do not have all these assay solutions from a single instrument platform. If they want to run all these prenatal screening, they may require more than one analyzers to use these assays from that platform. So that's an important information about the SNIPE, that we are the only company who's providing a very comprehensive menu for the prenatal screening. So if we compare So if we compare the Snipe free beta SCG as compared to the other competitors, we have two generations, Snipe first generation and Snipe two generations. And you know that what is the difference between the first generation and second generation? There's an improvement in the calibration intervals. There's an improvement in the limit of blank, limit of detection, and limit of quantitation. The measuring range or the linearity of the assays is improved. These are the key features on the basis that the SNIPE from the Megluni platform has a two generation of free beta SCG. If we compare the latest generation of beta SCG, that's we have an edge of 50 tests as compared to the conventional 100 testing. With that, we have a onboard stability, which is equally good to the other companies. While the other competitors, they have a comparatively less calibration intervals or onboard stability of the reagent calibration curve. We have optimum sample volumes as compared to the others. We have a good measuring range. We have a You can see here as compared to the linearity, we have a equally good linearity with the Siemens and the other competitors in the market. The other edge, we have a reagent onboard stability is equally good, and along with that, we have an edge in the calibrators and QC. Along from the Snipe platform, Meglumi analyzers, we have free of cost calibrators and controls, and these calibrated controls are along with the reagent. So if you are using any competitors analyzers, so you need to buy separately these calibrators and controls to perform testing on that, and then the expiry is also a big challenge. For us, there's a free calibrated control included in this. If we talk about the analyte PEPA, we have a PEPA assay, which has an unconventional assay utilization of 100 tests and the 50 test pack size. We have a sandwich technique for the detection of PEPA as a quantitative analyte. We have a serum recommendation calibration interval is 2 weeks with a sample volume of just 20 microliters. So the linearity of our assay is between 25 to 24,000 MIU per liter, and the onboard stability is 4 weeks. And along with that, we are providing one level of QC with the reagents and with the reagents. So that's an edge of our PEPA A and assay, along with the small pack size and the calibrators and controls within the reagent. So if we go to the comparison between the other competitors, like Roche, Beckman, Siemens, Snipe has an always edge of a smaller batch size. We have a same quantitative analysis with a sandwich technique, and we have a same sample type serum is recommended. Along with that, as compared to the others, we have a 14 days onboard stability, minimal sample volume, and the linearity is higher than as compared to the other competitors. So the less diluted samples of the sample dilution is required with the test kits. We can provide more patient reporting because due to the broad measuring range of SNIPE, Meglumi, PEPA assay. So the onboard stability is in some cases we are better than, and in some cases we are equally good as compared to the other competitors. And again, we have a very comprehensive solution for the PEPA A calibrators and controls from the SNIPE platform. So if we talk about the alpha fetoprotein, we have a pack size of alpha fetoprotein is a 50 test and 100 test. We have a sandwich quantitative technique with the serums, and the traceability of this alpha fetoprotein is against the WHO first standard international standard for the alpha fetoprotein. The calibration interval is recommended 14 days, with just a 20 microliter sample volume is required to perform patient alpha fetoprotein. We have a limit of blank and limit of detection, and we have a broad measuring range as compared to the competitors, and the onboard stability of 4 weeks, and then with the free of cost internal QC of one level is available. And if the customers don't want to use the SNIPE internal QC, and if they have some requirement of more than one level of QC, some labs want to use two levels of QC, and some labs want to use a three level of QC. So they can use Recast, Rendox third party QC, or ICAS third party QC for the alpha fetoprotein as a multi constituent analytes. So there are so many third party QCs, especially the Recast and ICAS are given a solution as a multi analytes. So with those single analytes, they can run multi analytes on Meglumi. But the Meglumi, the SNIPE is providing a solution from our platform that we are given a free of cost calibrated control with the reagent. So if we compare the alpha fetoprotein of SNIPE versus the other competitors like Roche, Siemens, and Abbott, we have again edge of 50 tests, while the other competitors are providing 100 tests or maybe a 500 test pack size, or 200 test and 1200 pack size, which is a very big pack size. Usually the alpha fetoprotein as an cancer marker or some prenatal screening markers, the assay utilization in any lab is rare as compared to the routine thyroid and fertility. That's why the SNIPE has this thought in an innovative way that they are providing a smaller pack size to be a provide from the every labs can perform these assays on automation with the low number of tests per kit. So if we talk about the detection principles, yes, we have a quantitative analysis through the sandwich procedures as compared to the other. They have a sample type of serum. We have a serum sample type. The other may have recommended the serum plasma, and the Siemens is providing a amniotic fluid, and then Abbott is providing a serum plasma and amniotic fluid validated on that. So if we talk about the calibration interval, we have a 14 days on board calibration stability as compared to the other. They have a 4 weeks stabilities, and some cases the reagent pack stability is 7 days. So they have written two stability, that's in 7 days and 14 days. So what does it mean? Basically, the competitors, if you are using the same reagent pack, you have to calibrate at 7 days. After 7 days, calibration is recommended if your 100 test kit is not consumed within 7 days. And if you are using the same lot after 28 days, you have to calibrate that reagent. But in SNIPE, we have a 14 days calibration stability. If you are using the same reagent pack, you can complete it in 14 days. If your workload is low, so then it's recommended to calibrate it after the 14 days. This is the quality guidelines from the manufacturers and the Westcard's quality standards for the calibration, the validity and stability performance point of view. If we talk about the sample volumes, we have an equally good sample volume as compared to the other competitors. We have a limit of blank, limit of detection. Along with that, we have an edge of, in some cases, as compared to the others. The other have a little bit higher linearity. But again, we have an onboard stabilities of 4 weeks as compared to the other. We have some 8 weeks and some 14 days to the 30 days. We have a free of cost calibration control included, but in other competitors like Abbott, Siemens, and Roche, you need to purchase separately calibrators and control. So this is a big task to maintain not only the reagent inventory as well as the calibration control, but from the Snipe platform, we have a liberty of having no requirement of calibrators and controls, separate ordering. We are providing free of cost with the instrument and with the reagent pack. We are providing the same. So if we talk about the free estriol, we have two generations of free estriol, and definitely they have an onboard stability improvement, and the sample type is also brought from serum to both serum and plasma. We have also improved measuring range. We have of onboard stability of 4 weeks. Calibrator controls are available. Only the free estriol Siemens is providing a solution, and their calibration stability is just 2 weeks as compared to our 28 days. And the only serum type is serum, but we are providing both serum and plasma, and they have only calibrators they are providing with them. Control need to be purchased for this free estriol assay from the Siemens platform. So this is about the apple-to-apple comparison between the other competitors and the Snipe product. And the second part, we will start right now with the more information about the PRECO, that's the prenatal screening software. So let's start. What is PRECO? Basically, it's a prenatal screening software. So the first step is how to register and how to log in the systems. Basically, this software is designed to screen the trisomy 21, that's a Down syndrome, or trisomy 18, that's an Edwards syndrome during the first trimesters and the second trimesters, and also the neural tube disorders during the second trimesters. So this software utilization is for the screening purpose. The first steps, you have to go to the screen like a user, Snipe, and the password is Snipe. Once you have logged in the systems, you have a screen of data entry, history, statistics, and settings. You have to go to the system and then reagent info. First, you have to go to the setting. Then you have to send the machine code. So this is the machine code area where you have a register info. So you have to send this machine code to the Snipe, and who will return the registration code based on the registration type. And then it's enter the return code into the key box and click the register button. Once you have put the code here, like 1, 2, 3, 4, 5. Suppose this was the code. Once you have put the code, you have to click the register. Once you have registers, now the software access is available, so you can use this software. The second step, the sample information. Once you have opened this PRECO software, which is a version was 1.17.9.5, and you have to make sure that you have installed a updated or the latest version of this PRECO prenatal screening software, and you have to go to the data entry. Once you have clicked the data entry here, then you have a patient information. So you have to put the sample ID, whichever is your sample ID. You have to put the name, like the patient name, the birth date. When you put the birth date, the system is calculate the age automatically, right? So then you have to click add. Once you have clicked add, and the next screen, there are 4 more information. So it's an input sample information. We have patient data, then you have to put the sample information. In the sample information, you have to put the weight. Okay, so you have to put the scan date, the CRL, antidates, and sample dates, along with the gestational calculation method, either through the LMP, either through the sampling date, and you have to go to the gestational week calculation from here. So once you have calculate the gestational weeks, then you have to calculate and then save. Once you have saved, you have to click the calculation button and then you have to save the gestational week. So in the next screen, you will see the input more sample information. What are the input sample information more? Like you have to put some race, like then Asian, African Americans, or some Russians race. So the other factors like of the patient, like she's smoking, she's diagnosed diabetic. They have a twins history, any IVF history. There is a nasal bones exist. The previous trisomy 21, if there, so that will be a more risk factors, the sending departments, and then the center's names and the examiner's details you can put. So after putting that data in the sample information area, you have to go to the test items. So you have to go to the test item like the pata A value or a free beta ECG value here, and then you have to the save to calculate the values. So once you have placed these value, then you have to go to the next screen. The next screen has in sample more information, which is an age risk factors. So you have to put the MOM values, MOM values. How do you put the MOM values? You can put here the age risk, the trisomy 21, 18, and 31, or the neural tubes. The diagnostic result with the less risk is will shows you on the basis of your MOM results, and diagnosis shows you that automatically. Okay, so this is the software. You have to put the patient values and the information, and then you can get the risk analysis of that. So the sample check. So how to check the sample results data in it? You have to go to the software as a sample entry. So you have to data enters like the date, or you want to search with a specific date, or you want to search a journal. Once you have put the date or desired date, on which date you want to check the sample data, then you have to click the desired patient. And then when you click it, and then it's you have to check it, and then you have an option that gives you the results. So you can check either, or you can uncheck, and then you can go to the next screen for the data analysis. So if you go to the next screen for the data analysis, you have an option of a print report as either a single report or a detailed report. So how you can print the report? You have to go to the data entry, you have to put the date, you have to put the sample, and once you have clicked this, you have to print. So once you have clicked, then another screen that's a prenatal report shows on your screen with the values and all details. And this you want to take a print, and then the print preview dialogues, you can click the print. So these two steps helps you to take a printout of your patient results for the from the software of the prenatal screening software. If you want to print a report as a batch print, more than one reports if you want to print, so you have to go to the history, and then you have to select all reports that you want to take a print for that samples. So once you have here, you have click it, and then this give you the risk above or cutoff, or your results values along with the 21-3 syndromes risks, or 18 trisomy syndrome risk about that. So this is the process, very easy and user friendly software. You have either you can print single report or a batch print. So if you want to go to the main menu, you have to check the login user and user period, and the remaining number of users are displayed in the title bar on the software main interface. So the more than one users can be used, and then they have a more flexibility for the results putting and then the data review statistically. So in the next step, the data entry. How to put the more data if you want to some have an each sample have a unique sample numbers. So for this purpose, you have to create a sample numbers should be with some unique identity. Like if you go to the data entry here, then you have click the date, and then you have select the patient, and then you have to put the sample numbers. So the sample numbers can be added automatically by the systems or manually enters. There are both options. So you can put automatically and manually as well. The sample know of the first added sample in the date is the current date plus 4-digit sample ID is by default, like current date, month, and along with the plus 4 dates digit ID. So the sample number for the newly added samples will increase progressively. Like if this sample is 923, the next sample ID will be the 924 if the sample number in the same day is run, and then gives you the data in the data entry stream. So the data entry, you have to check the LMP last menstrual cycle should be range between uh, you can see here, this is the range between the 15 to 45, and the gestational range is also between the 8 to 20 weeks. Between 8 to 13 weeks is considered as the first trimester, and 14 to 20 weeks period is considered as the second trimesters. And in this area, after have a gestational week and cycle time of 28 days, usually we are putting, and then it's an age factors upon that indicate that on the EDC value, so that the patient can be data can be put in here. So for getting the more information for that. For the prenatal screening, data entry is here. Like if you want to go to the patient, you have to go to the data entry, and then you have to go to the patient, and then you have to want to modify some information which is required, or you can modify here, like if some mistake in the name or some having some values need to be changed, or the scan date or the weight, any age or something you want to change, you can do the changes, and then you can save that. So there's one important thing about this changes is only the administrator access, or permissions are allowed to check or uncheck the samples. So only the administrators has right. So this is most important because operators can only upload the patient information or a data entry, but if you want to check and uncheck the samples, only the administrator have right. So once you have planned to install a prenatal screening software, you have to make sure that your administrator's password has some limited access. Otherwise, you may face some challenges for that. So we have a access limitation in this software as well. So if you talk about the history, if you want to see the history, then you have to open the history and perform action like viewing samples details and checking, unchecking in bulk and printing in bulk as well. So do this process, you can check bulk and then print as well the bulk. So the statistics, if you want to see the positive statistics with the gray area samples, once you have click it for the trisomy, and you have to enter the date here, positive statistics, and if you want to click the stats, and then you have to check the positive statistics here, click, and you have to start the date and end date. When you click the statistics button, you will see the results of statistics item in the list of the positive sample statistics. So these are the positive statistics. If need to count the samples in the gray area into the positive samples, check the positive stat, include the gray area samples. So this is very important. If you want to include the gray area samples into the positive area, like if here you have an area of gray area, So you want to check these gray area samples into the positive statistics. You have option of including these box into the positive feedback. So the prenatal statistics, again, they have a display the number of sample sands and also duration, each sample during this periods, and also you have to click this button to display the number of samples sent by each sending doctors during the period. So you can also check the period in which which physician has sent how many samples and how many samples data are according to the guidelines, the prenatal screening, they are positive or are borderline cases. So if we talk about more about the inspection statistics, about the mom statistics, you have to go to first the statistics, and then you have to go to the mom statistics. Like example, if you want to check the 2 months data, you have to select the duration from 2, and then what marker you want to check, the PAPA. So if you click the PAPA, you have to draw the mom statistics curves according to the set condition. When you have selected the date within the 31 days, the median value of the mom value of the markers is counted by the day. So if the selected date range between exceed the 31 days, the median value of the mom value of the marker is counted by the month. So again, this is very much important. The September mom based on from 1st September 2021 to 30th September 2021. The mom range is 0.9 to 1.1. In October, mom based on all patient, which is 1st October to 27 October 2021. And then the August mom based on the patient from 28 to 31st 8. So that's the selected data range exceed the 31 days. The median value of mom value of the marker is counted by the month. So this is the more important information during the calculation of mom statistics in this process. So if you click the systems and then tab into the system window to view the registration information and set doctor information, report information, print information, and other informations are available here. You can click different points, like here, if you want to click the reagent information, users, department, doctors, report, and then language as well. So all these informations are available in this areas about different for the systems as well. So if you talk about the system settings, if you go to the software, prenatal screening software, you have to go to the settings. Once you have clicked the setting, you can go to the median. So the median, it's basically a refill or modify the curves, cause if affect the interpretation of the results. If there is any requirement, you have to contact with the engineers. Otherwise, you can also do that through the freebie SCG formula that he there put. So you have to click the median, and you have to select the markers window to go to the median window. This is used to draw the median curve for the serum markers. So again, the median calculation can be modified through these procedures. And if you want to check the parameters, first of all, you have to go to the selector markers. Like you go to the median, and then you have to select the markers. After selecting the markers, you have to go to the data. And after go to the data, you have to search with which dates you want to search the median curve fittings. So once you have select the dates, and then you have to exclude. Once you have exclude that you want to exclude, there's a filter difference. You want to exclude for the median alert, either the twins, the diabetes, smoking, IVF, or any other risk, previous T21, nasal bone clearance. So all these you can check or uncheck that, and you can also include or exclude the following curves like low percentile or high percentile, whatever you have. So you can check, and then after having that, you can go to the fitting. So the manual fit not required. You can click the fit, and then you can click fitting. Once you have clicked the fitting, you have to click the graph. Once you have clicked the graph, and then you have to click the saves. So the minimum numbers for these data points of the median curves using for fitting the individual gestational is 50. So at least the data of 2 GAs is required. So the setting again, the median curve drawing is here. So you can see here, you have to select the marker, and then you have to select the graph. Once you have choose the manual input, either they choose a formula or input the four factors. There are two options. You have to click the draw. So it's also draw the, and then when you draw the saves and the manual input, you can put the formula A and B value manually, or you can use the automatically, and then you have a save. Once you have drawn, then save the, it will draw the graph for the statistics of median curve drawing setting. So if you have prenatal screening software like parameter settings, you have go to the parameters. You have to use the set risk cutoff value and suggestion diagnosis, like for the trisomy 334, the trisomy 21 in the gray zone. You have to set the gray zone if required. You have need to input the threshold value of the gray zone and then click enable. Then the denominator of the sample cutoff high risk cutoff value can be advised and warning message can be re-edited. So these are the all factors which can be conclude or we can run for the different statistics parameter setting. If they input high age and get the age standardization cutoff for the trisomy, you can also change according to your desired requirement for the parameter setting that you have. If we talk about the parameter settings, there is an use to set the reference ranges for the free beta HCG, alpha feto, Papa A, free estriol, and neurotube markers. So this is also an examples in which you can change or suggest or advise the reference ranges for that. So if you go to the more settings, there are also more display name used to select the display name of these markers and the comprehensive risk and the display format of the risk. If you want to use the default value of gestational calculation methods, so the race, smoking, twins, IVF, and the standing doctors are that important. So if you want to help to view the operating instructions, these are the operating instructions which helps you for the operating environment, what type of environment is required. Like if we talk about the processors, the RAM, hard disk, and the CD-ROMs, and the disk storage and transportation requirement is also mentioned in that help area of this software. So if we move the next question answers, like what is the requirement of operating system for that software installation? So the answer is the processors greater than 3.3 gigahertz is required. The RAM is almost greater than 4 GB. The hard disk should be greater than 500 gigabyte. The USB RJ45 and RS232 interface is required with the DVD-ROM operating system of Windows 7 or Windows 10. So the security software such as 360 Total Security, 360 Antivirus, Tencent PC Manager, or Kingsoft Antivirus are supported by our systems. So they can use all these security software for the protection of their data and the software. So how to edit the report format? For the report format, you have to open the templates and the Snipe reporter edit to edit. So through these procedures, you can edit the report. If you go to the method 2, you have to go to the setting. Then you have to go to the report and you have to click the edit. So there are very simple procedure in the software. You can do that. and then you edit the report. So the next question is, which folders do we need to back up before upgradation and installations? So once you are going to upgrade or install that Pico software, you need to take a backup of these seven folders, like common, configuration, database, doc, skin, template, and user manuals. So these are all the seven folders you need to take a backup for this purpose. Okay, Anton, do other companies have this software? Uh, I think, as far I know, the Abbott has a one software or a one software feature in their software. They call them a Roma. So the Siemens, as the Anton said, I honestly I don't know about the Siemens software. They have for the prenatal screening. If they have a Prisca soft, that could be. But I have this was not in my knowledge. Thank you very much, Anton, for this information. But I'm sure about the Abbott. Abbott has a software they use for the prenatal screening in different. So if we go to the next, how to send the report for the twins. This is important. Input the data of the twins separately, and you have to send the final report with the high risk one. If you have a twins, then the one says in a high risk, and the second one is not in the high risk, so you can need to send the different reports. So why does it show the value but the risk assessment for the neural tube disease? So you can see here the alpha fetoprotein value is 2 IUML and the mom is 0.04, and on the basis of this alpha fetoprotein results, trisomy 21 is a high risk. The risk for the neural tube is determined by only with the alpha fetoprotein between 12 to 14 weeks of gestational or 18 to 20 weeks of the gestational. That's why it shows you the risk assessment for the neural tube disorder. So this is all about that. If you have any question, you can ask, or otherwise we can take a break, 10 minutes break, or we can go to the next presentation. Whichever you like, it's up to you. You want to take a break or you want to go for a next presentation? Okay, so 15 minutes break is okay for you? Okay, so let's start break. Thank you. We will be back after 15 minutes, right? Snipe software have an advantage over Abbott's and Siemens software. Okay, I have to check. Kirill, I have to check because, but it's definitely because you see, when I was working in Abbott, I was not having such features of software. But if you need an apple to apple comparison, like this software has this features,